Living and dying. We spend most of our lives thinking about how we live, but rarely do we take a candid look at how to die the right way for ourselves and our families. Tonight, a rare and candid look at a controversial issue, right here on Voice of Reason. Hi everybody, I'm Larry Kane. It is not an easy subject to talk about, but one that must be talked about in a candid way, one that must be addressed in an alternative way, and in a religious way and a spiritual way as well. And so tonight we have a very unusual discussion here, the first time we've ever done this. Lauren Van Scoy, a pulmonary and critical care doctor at Hahnemann Hospital in Philadelphia, is the author of a very interesting book, Last Wish, Stories to Inspire a Peaceful Passing, and actually inspired this program. Dr. Mark Angelo is the director of palliative care at Cooper University Hospital in Camden, New Jersey, and Alicia Bloom is a social worker with VITAS Innovative Hospice Care in Philadelphia. First of all, Lauren, you're an intensive care doctor. What prompted you to write this book? I mean, it does read like a medical thriller, and it is a book that I wouldn't say popularizes, but makes people really think more about the end as well as everything else in between. What prompted you to write this?
Well, a lot of this was experiences that I sort of had as a young physician and sort of growing and developing through my training. And I was finding that in the intensive care unit, a lot of the families that I was encountering were having really hard times dealing with some of these end-of-life issues, and I was seeing the same thing over and over again. And it was interesting to me that I really wanted them to sort of learn from each other's experiences and talk to each other in the waiting rooms. And so I thought that by writing it down in a way that was compelling and easy to read and not medically sort of jargoned and written, that other people could learn from each other's experiences.
Well, some of the stories in here are really heartfelt. They're dramatic. Yeah. But it's interesting to read about it. It's different when you're there, isn't it?
It's very different when you're there. You have the professional side to you and you have the emotional side to you, and it's very important, and we get a lot of training as physicians to sort of keep those things separate. And one of the beautiful things about writing for me and writing this book was that I was able to take the emotional side of me and put it down on paper and talk about my feelings and talk about the experiences I was having, and also to interview the patients and their family members and to learn about their experiences and their feelings. And it taught me a lot as I was writing the book and talking to the people that I wrote about.
I have a hot question for you a little later, that after we get to the beginning here, but Dr. Mark Angelo, palliative care is something that people are starting to talk about more now. They're using the word more. They're thinking about it more in hospitals. Is it working for most families?
Yeah, absolutely. We've seen a massive explosion of palliative care over the last 5 years. We at Cooper have had a palliative care program now for 3 years, and everywhere you turn, you see hospitals are starting palliative care programs. There's a lot of different iterations of what a palliative care program is. And palliative care can mean very different things. In some patients, it's pain management at a very critical point of life, and in some patients, it's end-of-life care.
Okay, here's a key question for you.
Yes.
What happens in the healthcare environment today if someone is critically ill? There's not much chance of bringing that person back, and the doctors say that. But is there a tendency, and this is not directed at VITAS or your hospital, yours, is there a tendency for the hospital to push the family closer to palliative care as an efficiency for the family as well as the hospital? It's a very difficult question, and I'm not suggesting that anybody would do this.
Yeah, I absolutely get where your question and your concern may come from. The way that it really works is we have so many wonderful technologies that we have developed in medicine. With that gift of this technology, we have not learned where to apply that technology. We've not learned exactly who will benefit and who we really may be prolonging life for a very, very short time just to prolong suffering.
Which might cause that person to suffer more.
Absolutely. So I think, you know, the more difficult part is not to say where can we apply our technology, but it's where can we apply our technology intelligently? Where can we apply the technology to a point where it's going to be actually give meaningful help to someone?
Alicia, when you're dealing with your social worker with VITAS,
Yes.
and a family comes to you, and you're the person who has to sit down with them, along with the doctor team. They usually get a team together.
That's right.
And that must be, you know, that reality, that moment that they find out we can't save the person, or maybe we shouldn't save the person, and they have that family discussion.
Yeah.
Has to be the most difficult conversation in all of medicine, I would imagine.
I would agree, and I think the biggest challenge, and something that I really see in my work with patients and families at VITAS, is that they're so unprepared for the moment that this conversation is about to happen. And so we are sitting them down in a room, as Dr. Van Scoy and Dr. Angelo I know all too well, to share with them very difficult information that is going to change the way that they think about their own life and their future as people and as families.
Lauren, when you look at the book here, it's obvious to me that there's no one answer for everybody.
No, absolutely not.
And everybody thinks, well, there's an answer. We just do it, we just decide, and that's it.
Right.
How do you get to that moment where, first of all, you have the family meeting, or maybe you talk to the person if they're able to talk about it? How do you get to that moment?
Well, I think, you know, when you have in a family meeting, or you have to have these discussions, we try our best not to sort of intimidate the family or bring them into a room and sit them in a box. Usually it's the entire team helps us with the process, you know, starting with the nurses and the social workers, and even just the people around the ICU that have gotten to know, you know, the families day in and day out. And I think that, you know, when we have the patients and the families in the room together, we talk mostly about outcomes and what it is that they hope and what we hope that their expectations can be, and are those reasonable expectations. And that's really where we start with these meetings, not so much, you know, this is option A and option B, but we talk about what the meaningful outcomes might be, and we try to get to the bottom of what it is that they want and what they think their family member would want.
This is not summer beach reading, obviously. Okay, I mean, it's a very difficult book, but your foreword is written by Alexander Drain, award-winning co-founder of Engage with Grace, a movement to honor end-of-life wishes. Do hospitals really honor end-of-life wishes? I mean, does DNR, do not resuscitate, mean DNR in many cases?
Well, unfortunately, the way that unfortunately, our culture is such that we err on the side of saving lives, even when...
Because doctors are supposed to do that.
Right, we're supposed to save people, and that's sort of, you know, why most of us have gone into medicine, is to help people. But sometimes it's interesting to note that the way that you can help people the most is by stepping back. And because of our society and always, you know, the fear of, you know, lawsuits and litigation, we always err, if we have, and as we should, we err on the side of aggressive interventions. And that's, I think, sometimes where we get into a hard situation.
What is a peaceful passing?
Wow, that's a difficult...
And that's an hour program.
Yeah, that is an hour program in and of itself. For the most part, a peaceful passing is one where a patient is not in pain. A patient is not suffering. A patient is not nauseated or vomiting or short of breath. It's one where their loved ones can surround the bed. It's one where there's not a whole lot of surprises going on. It's one where everyone is prepared as we possibly can be. It's one where the environment is quiet. It's one where there are tissues in the room. It's one where there may be a supportive nurse to pop in and out of the room.
Nurses are very important, aren't they?
The nurses are really the most important part of the entire factor.
Definitely.
We talk about, you know, when the physicians get together and we have these family meetings, we can't exclude the nurse, because the reality is the physician makes the orders, then the physician walks out the door. So now the nurse has to carry out the orders, and the nurse will sit with the family, and the nurse will spend a lot of time with the family, and the nurse may have the patient at home on hospice and may be there with the patient regularly. So the nurse is really key in palliative care.
Nurses are the unsung heroes and heroines of American hospitals, aren't they?
I would say so.
Their impact, especially at moments like that.
It's really critical, and I think, you know, when we think about what makes a peaceful passing, and Dr. Angelo, you said something that I think is so important, and it's being prepared, and, you know, supporting patients and families through understanding what's ahead, so that they can make decisions that honor their values and their preferences. And I think, you know, that is what's so wonderful about this book, and the message of this book, which is having the conversations about what quality of life means, so that we as clinicians can then support people and families in making the right decisions for them. There's not a right or a wrong decision in any situation, but we want to make sure that we honor people's values and preferences.
Now, can you, you know, this is I'm sure it took you a long time to write this story. It's based on real life experience. Can you share one of the stories with us?
Sure.
It's hard to, in a few minutes, to share that, but I'd like to know at least one of the experiences.
Sure. Well, one of the stories is about a patient who unfortunately developed very, very sudden shortness of breath. Had been a very healthy, independent woman all her life, had a giant family, lots of grandchildren, and she unfortunately developed shortness of breath, came to the hospital thinking she was just having an allergy attack. Right. And lo and behold, she actually had very end-stage cancer, which was infiltrating a lot of the tissue in her lungs and was making it hard for her to breathe. And it came on rather suddenly, and within a period of just hours in a short day, she ended up on the mechanical ventilator. And because Victoria, the woman in the story, had never really thought about these issues or talked about it with her loved ones, her daughters, her grandchildren, about what her wishes were. Everyone was sort of scrambling to try to figure out what to do. Is this something mom would want, yes or no? And then once she got on the life support, they had to make the decision, you know, when they heard that it probably wasn't going to end well, that she probably would not be able to breathe on her own. They were faced with an even more difficult decision of, should we take her off the machine or should we keep her on the machine? And the story talks about the individuals, the doctors, the way that they felt, the nurses, their participation, the family members, and it really goes through the emotions that people feel, the fears, and hopefully will reach, you know, other families that may have similar situations, and will, I hope, inspire people to at least talk about these things with their loved ones, so that, you know, God forbid something does happen like that in your own family, you know what to do.
Should be a conversation.
Absolutely.
In addition to all the legal papers that you file.
Absolutely, and there's problems, of course, with the legal papers as well, which is why, you know, in the back of the book we have the End of Life Compass, which really does take people through those discussions that they have to have in order to have a meaningful and useful conversation rather than just checking off the boxes of an advance directive.
A book like this is certainly helpful, isn't it? I mean, you know, for people to maybe plan ahead. It's not the kind of book that you would say, got to read it tomorrow. It's the issue in the room that's always there, but it's probably very smart to read it, don't you think so?
Yeah, this is fantastic, because what it does is it brings to the forefront difficult conversations. We know that these things are difficult to talk about, but the problem is, if we don't talk about it, we're not giving that guidance that our loved ones need. You know, I heard a very good point mentioned a moment ago, that when we have patients like this, sometimes they don't have what we call an advance directive. An advance directive is a document or even a conversation that happens where someone says what their wishes would be if I should be in an unconscious state, if I should be unable to make my own decisions, if it looks like there may not be any reasonable hope for me to have a reasonable recovery.
And no advance directive could mean tremendous chaos and confusion. We'll be right back with our excellent panel here to talk about Last Wish right after this. You never know where you're going to get ideas from. I got a call about a month ago from a wonderful person in Doylestown, Mike Stockel, someone I've known for a long, Mike Stockel Jr., and he said, you've got to take a look at this book. And so if you ever have any ideas, let us know. And this is how we were introduced to Lauren Van Scoy, who wrote this book. When you wrote this book, what did your colleagues think about it? Is there mixed emotion about it?
There was a little bit of mixed emotion about it. I mean, most people were saying, oh yeah, you know, Lauren, that's a great idea, go write a book, sure. You know, but I found that I did all of it actually in my spare time, and I found it to be very therapeutic, and I found that as I was writing it and as I was showing it to my friends, my colleagues, they were asking to read more. It was written in a way that they weren't expecting. They were expecting it to be more of a sort of textbook, you know, how-to kind of thing. They weren't expecting it to be like fiction, and it reads like fiction even though it's all based on true stories. Yeah. So I got a very, very positive response from my colleagues and my mentors. The physicians that I work with were incredibly supportive. A lot of them have been interviewed, you know, for the book, and you know, it's just been really, really wonderful.
If I were hospitals in the area, I would take this book and put my symbol on the bottom and give it to everybody.
I would love that.
Every hospital in the nation should. Now, your organization is a standardized organization. You're around the country.
Yes, we are.
Do you work at particular hospitals or just everywhere?
Yeah, VITAS Innovative Hospice Care is the nation's leading hospice provider. We've been around since 1978, and we take care of people where they are. So we have the privilege of seeing patients and families in their homes, in nursing homes, and in hospital settings as well.
A lot of wonderful nursing facilities in this area, but more and more we hear, now we don't know specifically, that a lot of people would rather be at home.
Absolutely. I mean, when you look at the literature and you see what patients say they want at end of life, time and time again they say that they want to be at home. And they want to be, as Dr. Angelo said, pain-free and surrounded by their loved ones in a familiar setting. And so at VITAS, we're really committed to honoring people's wishes and giving them the choices they need to be in the setting that they want to be for their end-of-life care.
You obviously have a hospice section of the Hospital of Cooper, I presume?
No, we do not.
Oh, you do not?
No, we deliver palliative care wherever the patient may be.
So it could be at a
in the
nursing
ICU.
Facility or home. You think home is the best place?
You know, if you look at the data, 80% of people say that they would like to be home at the time of their passing. Yet significantly less than 50% are home. Actually closer to 25% actually are home. Because people will be in the hospitals or people will be in nursing facilities.
But if you're in a situation in a nursing facility, and generally the doctors and nurses will probably, no one can predict anything in life, but they know you're on a certain path, they can be sent home, right?
Absolutely, yeah. And that's really what our charge is. Our charge is, how can we make things happen for this person? How can we make things happen for this family? What can we do to make that transition to home successful so that we can really continue along that path of the optimal death, as you mentioned?
A question for you concerning the cost. I mean, I don't know anything about this. Fortunately, I've never been at this stage. I've seen a little bit of it with friends, you know, and things like that. Is this an expensive process?
Hospice care is actually an insurance benefit. It's a Medicare and Medicaid benefit. Private insurances cover hospice care as well. So,
how is it affected by the new health care law?
We don't know yet. We haven't seen any negative impacts, and we hope that, you know, people will still have the opportunity to get the end-of-life care that they need and they want, because it's really about empowering people to make choices and get the care that they want and the care that they need.
And I guess people should know they don't have to obsess about this every day.
No.
I mean, read a book like this, talk to your doctor, just to get it out of the way, right?
Absolutely. And usually what I suggest to people is, let's talk about your advance directive today, and then what I'd like to do is you'll sign it, I'll sign it, and then I want you to take it home and put it in a drawer.
Lock it up somewhere.
Yeah, and this way we can have access to it somewhere, your loved ones can have access to it somewhere, But this is not something that we need to dwell upon. We need to know what your wishes are. Maybe it needs to be revised in another year or something like that. But this is not something that we need to continue to readdress on a constant basis.
I was concerned at the top of the program when I mentioned it that there'd be a big click. People say, I don't want to hear about that. Right. But I think sometimes you have to hear about what's real. Are there any religious, social or spiritual opposition to this kind of theme?
Absolutely. I mean, I don't want to say opposition, but there certainly are religious and spiritual implications in what would be a dignified death or a peaceful passing for any individual, whether they're spiritual or not, regardless of whether they're, you know, of one religion or the other. The thing that's so, to me, amazing and interesting about end-of-life issues and death and dying is that it affects everyone on the planet, regardless of their age, their race, their religion, their socioeconomic status. This is something that affects everyone, and as physicians and clinicians, there's a very big push to make sure that in our care of patients that we respect and think about what patients' backgrounds and their religious beliefs and incorporate those into our family meetings and our discussions about what your wishes are and what it is that you would want us to do.
Well, maybe VITAS should get this book and distribute it nationwide. What do you think?
I'm
promoting the book here, obviously, but because I really...
I think that's a great idea.
I know Dr. Van Scoy likes that idea. I think that it's an incredibly important book with an incredibly valuable message, because I think one of the biggest challenges is that people are afraid of this topic. They're afraid to talk about death and dying, and as we all know, none of us are leaving here alive, right? None of us are getting out of here alive. And so I think the more that we can do to encourage people to have these conversations with their loved ones, the more empowered they are to have control over their care.
Interesting aspect of this, Dr. Angelo, is the idea that you're not only taking care of yourself, but you're also probably making the road a lot easier for the people who love you. Which is, you know,
Absolutely.
I mean, death, no matter how much you prepare for it, when it actually happens, it's very, very sudden and striking to most people, but in this way it might make it a lot easier.
Yeah, absolutely. And in palliative care, we do consider that the patient is the primary target, but really we focus around the whole family too. So we have to bring in loved ones because we realize that someone's disease affects how their husband sees them, and it may affect how their children see them. And there are so many aspects to delivering good care at the end of life. This is why when we talk about palliative care, we talk about what we call an interdisciplinary team. Interdisciplinary team is made up of a physician, it's made up of a nurse, it's made up of a social worker. We bring in spiritual care in many different iterations. So what we do is we try to bring everyone to the table to say, how can we help this patient, how can we help their family, and what can we do to really make this the best experience and have this family come through this as emotionally intact as we possibly can.
I'm just curious, what's your own family's reaction to this, besides the fact that they've got an author?
I have a very large family. I'm blessed. I have 4 parents rather than just 2, and for various reasons. And you know,
we really weren't getting into that, but that's okay.
Well, what I'm trying to say is that everyone has a different reaction. You know, one member of my family is, you know, she's very afraid of needles and hospitals and doctors and medical problems, and this was a hard pill to swallow for her, I think. Whereas there's other members of my family that we've talked, it's actually helped promote awareness for them, and we've talked about these issues, and I feel more prepared having had discussions with them, you know, about even stories in the book. They just serve as a discussion guide or a platter for us to talk about, oh, I would want this, or I wouldn't want this, or what happened to Victoria I wouldn't want to happen to me. I don't want you to have to go through what Mrs. Chandler's family went through, those sorts of things.
Now, I would have to say that hiring people in this field has got to be one of the most exhaustive and difficult and agonizing choices. Am I right?
Absolutely. Hiring anybody is not particularly easy, but when we're talking about people who tend to go into the field of hospice and palliative care, these are people who are truly dedicated. Yes. These are people who are so dedicated to the mission of taking care of patients. This isn't a massive money-making effort. The reason that people choose this as a field is that you're passionate about it.
Absolutely.
Now, you've chosen this as a field.
Absolutely.
I mean, you can't find a rougher field to be in with an emotion. Does it take an emotional toll on you?
It can at times. However, I think the work is a privilege. You know, the opportunity that I have at VITAS to be with patients and families as they make difficult decisions and approach end of life is really an honor. And I think all of us that work in the field feel that sense of honor and privilege.
We're running out of time. I just have a question for you, Lauren Van Scoy. The people who are mentioned in here, were they okay with you telling the stories?
Yes, I spoke all of the names, and a lot of the identifying characteristics have been changed. A lot of them participated actively in giving me the interviews, telling me their life stories, and allowing me to write about them. But I did change, of course, for privacy reasons, all of the names and information.
But they were okay with you telling the stories?
Yes.
And that shows a lot of unselfishness on their part.
Yes, it does.
Last Wish by Dr. Lauren Van Scoy, a native of this area, and we thank her for coming on along with Alicia Bloom and Dr. Mark Angelo, Director of Palliative Care at Cooper University Hospital. Thanks for watching. It's a difficult subject, but certainly one that has to be talked about rather now than later. Have a great night.